Hello everyone, and welcome today on the topic or the session of anemia in pregnancy, brought to you by Apollo Cradle. To speak on this topic, we have Dr. Nagaratna from Koramangala Center in Bangalore. She is an internal consultant as a gynecologist and obstetricians associated with Koramangala Center, and she's going to speak about the topic of anemia in pregnancy. Ma'am, we are looking forward to hear from you because this is one of the most important topic and most important concern of many patients who are anemic in pregnancy, and what should be done to take care of that is what is important. So we are looking forward to hear from you, ma'am. Thank you. Ma'am, you can start on the topic. Ma'am, you can start the topic.
Okay. Hello, everybody. Namaste. Good afternoon. Today, I will be talking about anemia in pregnancy. I am associated with Apollo Cradle Koramangala, Bangalore. So, let us discuss about anemia. So, what is anemia? Anemia is defined as a reduction in the circulating hemoglobin mass below the critical level. The normal hemoglobin is 12 to 14 gram percent. WHO is accepted as 11 gram as the normal hemoglobin in pregnancy. Therefore, any hemoglobin below 11 gram in pregnancy can be considered as anemia. So anemia is present in very high percentage of women in India. Exact data is not available about the prevalence of nutritional anemia. However, according to WHO, the prevalence of anemia in pregnancy is almost more than 50%, 50 to 56%. In India, it has been noted as high as 40 to 75%. So the iron requirement in pregnancy increases a lot. Mainly, we will be concentrating today on iron deficiency anemia, and mainly anemia is due to iron deficiency and acute blood loss in pregnancy. We will be focusing only on iron deficiency anemia. So there is a blood volume expansion by a mean percentage of about almost 50% in pregnancy. The plasma volume increases disproportionately compared to the red cell mass, which results in a physiological decrease in the hematocrit. Anemia in non-pregnant is defined as hemoglobin less than 12 gram percent and less than 10 gram in pregnancy and puerperium. So hemoglobin will be very low in the mid-pregnancy. CDC has defined anemia as less than 11 gram in the first and third trimesters and less than 10.5 gram in the second trimester. A precise definition of anemia is very complicated, actually, because of the normal differences in the concentration of the hemoglobin between men, women, white, black, between pregnant, non-pregnant, etc. So, what are the causes of anemia? The causes of anemia are acquired and hereditary. The acquired causes, as I told you, iron deficiency, anemia caused by acute blood loss, anemia of inflammation or malignancy, megaloblastic anemia, acquired hemolytic anemia, aplastic or hypoplastic anemia. Hereditary anemias, thalassemia, sickle cell hemoglobinopathies, hereditary hemolytic anemia, etc. In a typical gestation with a single fetus, the maternal need for iron induced by pregnancy averages close to about 800 milligram, about 300 milligram for the fetus, placenta, and 500 milligram for maternal hemoglobin. Mass expansion. Approximately 200 mg more are shed through the gut, urine, and the skin, and this 1000 mg exceeds considerably the iron stores of most women. So there is total iron requirement is 1000 mg, fetus and placenta 300, increase in the red blood cell mass is 500, and basal loss will be 200. The average requirement will be 4 to 6 milligram per day, 2.5 milligram per day in early pregnancy, 5.5 per day from 20 to 32 weeks, and 6 to 8 kilogram per day from 32 weeks onwards. So we classify anemia also as mild, moderate, and severe. Mild degree is around 9 to 11 gram percent. Moderate is 7 to 9 gram percent, and severe will be 4 to 7 gram percent. Very severe is less than 4 gram percent, and also it can be classified according to the hematocrit or the packed cell volume percentage. See, what are the maternal risk factors? So, risk factors, if we take it, we can divide it into antenatal period, the intranatal, and the postnatal periods. Antenatal period, it can lead to poor weight gain, preterm labor, pregnancy-induced hypertension, placenta previa, and PROM. The intranatal period, there can be dysfunctional labor, intranatal hemorrhage, shock, cardiac failure, and there is also risk of anesthesia. Postnatal period can lead to postnatal sepsis, subinvolution, and embolism. The fetal and the neonatal risks can be prematurity, low birth weight, poor APGAR score, fetal distress, and neonatal anemia. The causes, first I explained you the physiological cause, then it comes nutritional. Nutritional, there is iron and iron deficiency, folate or vitamin B12 deficiency, and dimorphic, hemorrhagic, hemoglobinopathies, hemolytic, and aplastic anemia. Symptoms, the clinical presentation. The symptoms can be just a generalized fatigue, weakness, loss of appetite, digestive upset, dyspnea, and palpitation will come to severe anemia, and there is also edema in severe anemia. We have a lot of investigations, basically the blood tests we do. Simple blood test of hemoglobin or the complete blood picture will give us the diagnosis. We do a peripheral smear to see a hypochromic picture of the cells. We also do the total iron binding capacity, serum iron, serum ferritin. Routinely, we don't do in pregnancy because it is a straightforward case. We have also so many special tests, but usually it is not done. What are the prophylactic measures we can take to prevent? So the prophylactic measures, the routine screening for anemia, starting from the adolescent age for the girls from the school days. And we should also encourage iron-rich food, fortification of widely consumed food with iron, providing iron supplementation from school days, and preparing the girl for the prevention of anemia. Prevention of iron deficiency. The prophylaxis of non-pregnant women, we can give 60 milligram of elemental iron daily for 3 months. And iron supplementation, we routinely do during pregnancy. Routine iron supplementation is debatable in Western countries, but in India, mandatorily, we give iron to all pregnant women. Universal iron supplementation for pregnant women, about 60 milligram of elemental iron and 400 microgram of folic acid for 6 months in pregnancy and additional of 3 months postpartum, where the prevalence is more than 40% is recommended. The government of India also recommends 100 milligram of elemental iron with 500 microgram of folic acid, especially in the second half of the pregnancy for at least 100 days, or 2 injections of iron dextran IM at 4 weeks interval along with the TT injections. That is also can be given. There can be different common causes like hookworm infestation can be dealt with albendazole or mebendazole. Also, the prevention of anemia is mainly by consuming iron-rich food. Iron-rich food comes in pulses, cereals, jaggery, any dish made out of jaggery, beetroots, green leafy vegetables, meat, liver, egg, fish, legumes, dry beans, etc., etc. So, what are the effects of anemia in pregnancy? The mother, during pregnancy, there can be cardiac failure at 30 to 34 weeks of pregnancy, increased susceptibility to infection. Anemia is an invitation for any infection as such. Can lead to preterm labor, more in chances of preeclampsia. Then during labor, it can lead to uterine inertia, can lead to postpartum hemorrhage, leading to further loss of blood and further anemia, blood loss anemia, cardiac failure, and shock. In the puerperal period, that is after delivery, there can be a cardiac failure, puerperal sepsis, subinvolution. Failing lactation, there can be problem in lactation also because of anemia. Chronic ill health, backache, and in the baby or the fetus, we can notice prematurity, IUGR, intrauterine growth retardation, increased perinatal death, and decreased iron stores in the neonate because of the anemia in the mother. So, managing anemia is mainly by oral iron therapy, which is a very safe, inexpensive, and effective way of managing anemia. Nutritional anemia prophylaxis, we usually give 60 milligram of elemental iron and 500 microgram of folic acid every day. However, it is suggested that 120 milligram of elemental iron and 1 milligram of folic acid are the optimal daily dose needed because of the absorption problems. Side effects of oral iron can be, there will be, many people will present with nausea, gastric discomfort, loss of appetite, staining of the teeth, and they can also have constipation, diarrhea, flatulence. These can be some of the side effects which can lead to non-compliance in the consumption of oral iron. There is also parenteral therapy, which is given in the form of injections. Injections, we have intramuscular injections, and latest we have the intravenous infusions also. Very severe anemia, we have blood transfusions. Intravenous iron, uh, we have the total dose almost 50 milligram of interferon can be given. Uh, there can be complications with IV iron. Blood transfusion is indicated when it is less than 6 gram per DL. The diet rich food, I insist on the consumption of all green leafy vegetables. I already told you the diet rich in iron, pulses, cereals, jaggery, uh, green leafy vegetables like spinach, non vegetarian meat, liver, fish, legumes, and dry beans. These are all the food which is rich diet and rich in iron. So daily consumption in an extra amount, especially for this not pregnant women, we can prevent anemia. Whether diet rich in iron is taken or no, this supplementation of oral iron is very important, and it has to be taken by all pregnant women. So I conclude, and it's open for discussion.
Ma'am, there are certain questions. Two questions are there. If you could answer.
Yeah. Anemia during pregnancy, does it have any effect on the fetus? I told you yes. I think I told you. Uh, it does have a effect on the fetus. It can lead to premature labor. It can lead to a low birth weight in the baby, and it can lead to fetal distress, can lead to neonatal anemia, and can have poor up. These are the things which can happen to the fetus due to anemia in the mother. Many says it is common to be anemic. Yes, that's what I think I explained in the beginning. It is common to be anemic during pregnancy, physiological anemia we call that as, because there is an expansion of the plasma volume and the blood volume in pregnancy. The blood volume more than 50% is increased, but plasma volume is increasing disproportionately compared to the red cell mass, and that results in the physiological drop in the hematocrit. That is the anemia in pregnancy, which is more in the second trimester. First trimester and third trimester, there is anemia, but the maximum drop expansion happens in the second trimester, and that is when there is drop in the hemoglobin in the second trimester in pregnancy. Many says, is it common to be anemic during? Yes, it is true. I explained to you that. Okay. You can conclude with the concluding message.
Ma'am, no more questions. We can conclude. If you have any message to be given, we can say that and we can conclude the session.
Yeah. So, all pregnant women need to take care of anemia. Oral iron supplementation will be given by all the doctors. It has to be taken. Please take iron regularly and let us prevent anemia in pregnancy.
Thank you, ma'am. Thank you so much. Thank
Thank
you
you.
for the session. It was wonderful to know what precautions and what things to be done to avoid anemia or to treat anemia in pregnancy. Thank you very much. We'll end the broadcast here.
Thank you.
Thanks.